beautiful background.
Good afternoon and welcome to Grand Rounds today. I'll start by reminding everybody that there will be no Grand Rounds next Wednesday. Also remind you to fill out the attendance record in the back of the auditorium, and also please fill out the program evaluations and give the CME committee any ideas you might have in regards to future topics or future speakers. I think that today's topic is really an excellent topic, and so big that we actually have co-presenters. Our presenters today are Dana Bernard, who is a physical therapist here at MGMC and a neurology clinical specialist, and Dr. Selden Spencer, a neurologist and polysomnographer extraordinaire. And they're here to discuss walking, falling, and balance. And please join me in welcoming Dr. Spencer and Dana Bernard.
Okay, thank you. Good afternoon. Thank you very much for coming. Many thanks to the committee for having this session and for Dana Bernard to participate in it. I'm going to kind of do the sciencey part of it, to kind of talk a little bit about locomotion, walking, and then Dana is going to be the more practical, what are we going to do about it type of thing. I also want to give thanks to Jane Smiley-Oyen at the Neuromotor Control Lab at ISU at the Faulkner Building. For all of you, feel free to access that wonderful resource for your patients or for yourself. They're always looking for subjects for research. They're always talking and leaving material at the neurology department for Parkinson's patients particularly. They're interested in having them for subjects and their efforts. So, here we go. So that's my outline, and I have this fear that I'm not looking at the right study here, Tim, but I've done a number of iterations. But I'm going to talk a little bit about the neuroscience of walking and then talk about walking disorders. I think it's kind of your due diligence. This is what neurologists do every day. We want to see our patients walk. And you learn a lot by looking at them walking. But that is the segue then to the whole subject of falling and what we can do about it, which hopefully Dana will help. And I'll be about 20 minutes, and then she'll be the rest of it. Okay. Oh, I know what I'm doing wrong. Maybe this is what I'm doing. Okay, so this is a beautiful thing. I'm going to just 2 slides about the physics of walking, and there's tons and tons of material about this, but the simple idea to capture is that stride is energy consuming. Getting you up to that peak here is a wonderful time where you can then slide downward. And it's a very energy efficient model referred to as an oscillating bipendulum. And what you're looking at is a combination of 4 or 5 basic muscle patterns. They're called modules that are timed at different phases of the gait cycle. You have plus 50 muscles in your leg, and then you coordinate those 25 muscles that are really key for swinging and standing. And it's all directed by a locomotor central pattern generator, which is very fascinating, in the spinal cord, which is innate. You're born with it. But oddly enough, it's very modifiable, and I thought that's going to be a little curiosity that we're going to talk about for a few slides later on. So you break it down. Here's your gait. You're swinging through, and then you're coming to a standing position, and then swinging again, alternating left and right. And naturally, you're going to have the quadriceps tightening up to bring that knee up, and you're going to have your gluteals tightening up to hold your stance, and these have very distinct patterns that are organized on a spinal level to happen. But the innate nature of it, the pattern generator, I'm going to just take a little look at it. Here's a newborn. And there is the gait. Fresh out of the oven, and it has everything. The quadriceps are doing what they're supposed to do. The gluteals are doing what they're supposed to do. But then, they just kind of lay like a blob for a while, and then they kind of roll over magically, and then they crawl, I mean, a deer, they come out, they get up on their feet, they start running, right? And they evade the wolf. Humans don't do that. So just the whole question of, well, what the heck's going on for those first 2 years, and why uh, does that not model after the rest of the nature is unclear. So just a few slides about the central pattern generator, which is in the spinal cord, and there's another slide coming up here that'll organize it in terms of the nervous system. But as you might imagine, you have your module that is all about extensor muscles and your module that's all about flexor muscles, and they have to communicate left and right in an alternating fashion to create that wonderful, efficient pendulum. And so just a slide to talk about all these central pattern generators. It's not just the spinal cord, the reflexes down in the lumbar region, but it's referable to respirations, chewing, eye movements. These are all involuntary patterns that are organized and go on with or without your thinking particularly. But they certainly can be modified upstream by the cortex, by the thalamus, basal ganglia. And indeed, you can get rid of all the front part and stimulate the midbrain and still have very good walking abilities. So this is the part that I really find most fascinating, is the rhythm generator. I mean, I understand the pattern formation. So we have a set of neurons that are going to stimulate the extensor muscles in module 1 or whatever. But it's the ability to have cells in the spinal cord that are constantly boom, 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 and then regulated a little bit upstream that we don't really understand. There's tons and tons of research talking about this neurotransmitter and this receptor, but it's really not very well understood. When it comes to breathing, I mean, I think that's a lot more well studied and understood, but it's still interesting that the nervous system has these things that just kind of constantly fire off. And so again, looking at the ventral part of the spinal cord, you will have the famous Renshaw cell, which will at the same time turn off the flexor muscles, at the same time it's turning on the extensor muscles, and you can imagine a network of these cells that regulate the pattern, but are driven by a rhythm-generating set of cells which you don't understand very well. So I just throw this in for entertainment because it's not necessary for us to be bipedal. And there was a big stir about 10 years ago about this family from Turkey discovered by a Dr. Unurtan. And there's a BBC documentary, and you go back, and these people get around just fine on all fours. The stir at the time was, oh my gosh, you know, maybe there are genetics that determine our walking upright versus walking on all fours. And if you go to the Wikipedia and look up Unurtan, you'll see a very caustic comments about this whole subject. But I'll tell you the brief, this guy, 17 people in this family, and it's the last 5 that had this kind of gait. And this gentleman here can walk upright, but it's an ugly thing to see him walk upright. He's very ataxic, very clumsy. And it is just more efficient for them to walk on all fours than it is upright. So with this background, what could possibly go wrong? So anything with the cerebellum, basal ganglia, cerebral input to this central pattern generator can screw things up pretty well, and you can have problems with the nerve and muscle that screw up your walking, and skeletal problems that cause. So now this is the point in the program where I'm going to hopefully not embarrass myself, but you can have audience participation, because I'm going to demonstrate these gaits, and you can guess which gait you're what, and what does that tell you about the nervous system, or what is going wrong. So the first one is pretty simple, and you'll see this in the hallway. Anybody? Anybody? Little hemiparetic gait, right? With spasticity in the arm. Coming back, you'll see this in the hallways too. Now you're going to say Parkinson's, but look a little closer. I'm not sure, no tremor. I'm just going short, choppy steps. That's petit à pas. That's the short walk, the march that is due to many subcortical injuries to the brain. Getting on to neuromuscular disease, you see somebody having a very dramatic step, the steppage gait. That's neuromuscular. That's a loss of the ankle flexion, foot drop, if you will. And then if you start to see people going along the hallway like this, wide base like that, that's not cerebellar. That's, again, myopathic, something with the pelvis, all kinds of variations on that. You get into the cerebellum, and what would you expect? They're going to be wide-based, and they are just not very steady getting down the hallway like that. Now, if you throw in stuff with the arms and the face, then you think more about the choreiform type of gait disorders. And I don't think I'm going to demonstrate the psychogenic gait, except to tell you that if they are all over the place and not falling, it's probably psychogenic, okay? So that's the highlights of that. So now we move on to the subject of falling, and this is very relevant, and it's kind of a huge issue in terms of cost and damage, and it's just amazing. 1 in 3 people over 65 will have a fall. Leading cause of fatal and non-fatal injuries. Most common cause of traumatic brain injury and fracture. I'm on call today. What call did I get from the emergency room? Elderly woman falling with a small subdural. It happens all the time. So preventing falls is a huge subject. Estimated costs, you can read that, and it is a pyramid. Every year, estimated 1.6 million people having a fall sufficient enough that they go to the emergency room. So it's a huge issue. And it has been studied probably for 20 years, and Tinetti and a lot of other people publish a lot of things, but these are the factors. You've got them in your handout. Is there something wrong with their gait? And we'll talk about that in a minute. Is there anything in terms of medications that can be addressed? This is the part that I'm most interested in, and I mentioned this earlier. The whole issue of the relationship between cognition and walking is profound, and I'll have some slides to talk about that in a moment. Obviously, having the rugs and absence of handbars and things like that are a problem. If you've had one fall, your risk goes way up. That's the number one risk. If you can't see very well, that's a huge problem. Surprisingly, strength, which is amazingly something you can do something about, getting your patients strong, can benefit them tremendously. Imbalance, well, we'll get into that a little bit, and actually Dana is going to do more about that than I will, but the risk exponentially increases as the more factors you have. So what do you do to prevent it? Obviously, correct the vision, improve the environment. As I said, getting them this stronger through their hip flexors and through their quads can reduce falls tremendously. Balance training with Tai Chi, vitamin D for fractures, reduce cognition. There isn't any prevention there. All right, and so I just thought I'd put in one table, and this is an old study, about 10, 15 years old, but you can do these different things, whether they're done on a community base or you order them from your office and send them to physical therapy. You do have an evidence that you can reduce the risk of falling through these efforts. So just talking about gait, remember gait is one of the many problems that can cause falls. I'm just fascinated that the speed of the gait is a key variable. And basically, you don't want variability. You want a fast gait, but you want the stride length to be the same. You want the rhythm of the step the same. All that variability, any variability is bad news and makes you more prone to falling. There are lots of details that people get into and can analyze, but if you can just keep that in mind, looking at your patient's gait and whether or not there's a lot of variability in their gait, maybe that by itself would be prompt your interest in getting a referral to physical therapy. And then how are you going to measure gait? I am still of the mindset, along with fitness, that is a vital sign, Steve and colleagues, that if we could do something to just have a 20-meter walking speed analysis as a vital sign, along with blood pressure, it might be a long way toward identifying people that have gait problems. And Dana will do a nice analysis of some of these, so I'm going to skip on that. But I do want to mention again, variability in the stride time, the length of the stride is bad. We don't want variability. So if it's less than 70 centimeters per second, they're increased risk. And I also mentioned that. References there. I wonder whether you might be able to get, and I don't think there's been a study to this effect, that getting them on a gait on a treadmill where they are demanding to have a regular speed might resolve and be retrained to have a regular stride length and a regular rhythm. Just one slide about cognition and gait. Those of you who were here previously about the dementia stuff, I mentioned the bad boy, which is the default mode network. Again, remember, in the brain, you have series of nuclei in the brain that activate together, go up and down in their activity. And the one that seems to be where we all go as old people is the default mode network, which is kind of where we ruminate. We worry about things, and we have, feelings of, I don't know. We think about things. We're not in the present, shall we say. And what you can find with people just doing simple tasks like finger tapping or just sitting there at rest, that the people that fall have a lot more time spent in the default mode network as it connects with the, we have a question.
Walking, unobserved natural walking speed, is that what you're referring to?
Yeah, you're right. I mean, there's going to be the whole issue of performance, and but I don't see any way around it. I mean, I think you want to say, hey, we're going to go back to the room, and you know how far that distance is, let's go. And the nurse charges down the hallway anyway, and so let's have the time of how long it takes for the patient to get there. So back to this whole subject, what you can demonstrate in finger tapping is that as the default mode network connects with the frontal parietal, it goes up in fallers, whereas in the sensory motor connections with the frontal parietal, it goes down. So stuff is happening in the brain which we really can't touch and influence a whole lot, that predicts falling. So this is about the end. This is a genetic pattern. I think Dana will probably talk about this a little bit more. And I was going to go on for about 15 minutes about these different elements. But as a practical matter, and perhaps for all of you as you're seeing patients or interacting patients, I always tell patients, look, if you're going to stand and walk, you're going to have 4 things. You're going to have to feel the ground, you're going to have a good gyroscope, and you're going to have good vision and a good computer. Any one of those things go bad, you're not going to walk very well. And again, I'm so happy Dana is here because she can analyze this and sort out the relative contribution of these different variables. So with that, we'll turn you over to Brittany Spears' microphone, and you can take over. Oh, you're already set? Yep. All right, so I'll just turn this off.
All right. Good afternoon, everyone. I am so appreciative of the opportunity to be here speaking with Dr. Spencer about this topic. I'm going to go to my laptop here. All right. So the relationship between gait, balance, and falls prevention is really quite complex. And even though this is my area of expertise, that it continues to confound me every day with the patients and the complexity that we have with our patients. However, there are a few tools out there that I think will really help us be more efficient and more consistent with what we do with our patients to analyze and to make referrals. So if only it were this easy, but it's not. Well, Dr. Spencer talked about how it's important to have the somatosensory system, the visual system, and the vestibular system all working together for balance. But we also know that those are the inputs we need for balance. We also have to have the motor outputs. So you have to have the strength, the coordination, the fitness level, all have to be present in order for you to have good coordinated balance. But there are many more things that influence balance and require that we take a look at those things, such as the task that the person is doing. What is their flexibility? What is their emotion or their motivation to doing the task? Their cognition, the environment, other people. Are they carrying a grandchild? Are they having to move around other people? Distractions in the environment, posture plays a huge part in that. So we need to look at all of these things, and there's many more that can come into play too. So whenever we talk about balance, we kind of have to start with static balance, which is the ability just to sit or stand still. It does require sensory input and requires the motor output, but can be influenced by many factors. It's always the simplest place to start for static balance with balance examination. But the problem is that we don't function in a static balance position. We are always moving, we're always doing things. Even as I'm standing here, my vision has to change, my head movement has to change, and I'm also doing some movement across my feet. So this isn't where we function well. When we get to talking about the recommendations for that the CDC has put out for fall prevention, one of the tests that they recommend is the 4-stage balance test. And this is a very simple test, and we'll talk about this more later, but a person that has static balance problems will fail the 4-stage balance test. Also, if you're bringing a patient back into an exam room and you have them step on the scale, this will be the patient that cannot stand on the scale without you feeling like you need to touch them or have them hold on to something. That's a cue that this person has some static balance deficits. So the next step we would look at would be the dynamic balance system. Dynamic balance is the ability to perform movement tasks while we're balancing. So gait is a dynamic balance example. Being able to reach into a cupboard while you're standing is dynamic balance. It can also be very layered because you can be doing gait as you're doing head turns or as you're doing head turns and reaching. So that's a dynamic balance. So when you look at a patient that has dynamic balance deficits, you're going to see that they have a slower timed up and go test. We'll also refer to that as the tug. And Dr. Spencer had included that in his slides. And actually the timed up and go is one of the reportable documentations for fall risks that need to be in patient charts with examinations in order to get more funding because you're doing proper patient care. So when you're walking with a patient that has dynamic balance deficits and you're bringing them back into the office, they will be the patient that if they turn to talk to you, they kind of do a little stagger. They will also be the ones that might run their hand along the wall because they know they're not very stable. Or it could be the person that will not turn and look at you. They keep their head straight ahead. They're not going to turn to talk to you. They're going to keep moving with their head straight ahead because they know they're going to lose their balance if they turn their head. And then we have to add on dual tasking. There have been many more studies within the physical therapy world, and especially with Parkinson's diagnoses, about dual task abilities. Dual task balance is the ability to balance while you're involved with another task. And that second task can be cognitive, fine motor, or gross motor. And many of our clients, though, are really unable to continue to do this without increased risk of falling. So that is one area that we need to consider. Dual task balance is, again, more of a functional type of balance, and it can be layered on top of a dynamic balance skill. So if you're walking back with a patient into the room and they're trying to look at something like their calendar, and as they're doing that, they're kind of staggering, or they have to stop to look at it and can't do both tasks at the same time, that is an example of someone that would be having problems with dual tasking. Now, most of us actually usually do triple and quadruple tasking, but we really need to give our patients that are having balance deficits more information and more guidance so that they're not doing as many of these dual tasks, so we can decrease their incidence of falls. As Dr. Spencer said, cognition is very important when we talk about balance programs, mainly because of safety judgment, ability to learn new strategies, ability to remember to use their assistive devices, and it also gives us a window into their overall neurological function. Patients that might cause concern for you would be the patient that leaves their cane back in the waiting room and staggers back to the exam room before they realize that they forgot their cane back there. Or it can also be the person that is using a walker, but they leave their walker out in the hallway and they grab hold of this and they grab hold of, go to the exam table, see the chair over here, and dive for it. How many of you have seen that before? We see it quite often. But one of the things is that the people that are at your front office are probably going to see it more than you do, even. And I would really encourage your front office staff to give some input to nurses and the physicians about concerns when they see somebody doing that type of behavior. And believe it or not, I have had a patient that she needed to change a light bulb, and she put a chair on top of a bed and climbed on it and fell off. This is an example of a problem with cognition. And I have found that working with patients that have cognitive problems is probably the most challenging area because, number one, sometimes they refuse to use an assistive device. You really have to use family, friends, facility staff, whoever you can to implement some changes. So where do you start with examining the patient and finding out if they're at fall risk? Well, fortunately, the research has been done and done and done. There is lots of research out there. It's been gathered, it's been scrutinized, it's been published, and it's been assimilated for best practice by the CDC. It involves use of a patient questionnaire, testing of the patient with some very simple mobility and balance tests, patient handouts that you can give them, and the information is available through the CDC with the study, Stopping Elderly Accidents, Deaths, and Injuries. I think that if we can use this, we can really make our treatments and assessments more consistent, more effective, and more timely with our elderly patient population. So this is the website here, and I actually have this right on my laptop here, and you can download, let's see, I got the wrong mouse here. You can actually download this and put this right onto your desktop. This is what the website looks like. And it has information for the patient to fill out. It has an algorithm for you to use. And some of these I have printed out here. But like I said, you can put this right on your desktop within the exam rooms, in your offices, at the front desks, and even in the other clinics, radiology, oncology, radiology, because these don't require a nurse or a physician or anybody else specific to do this. We all have the responsibility of identifying these problems. Does anybody know how to get rid of this message? I get it constantly. down at the bottom of the website, it's got the brochures you can all print out, and they're available in English and Spanish versions. Oh, okay. So this is the algorithm. I'm not going to spend a lot of time because I'm going to break this down a little bit more, but that's what the algorithm looks like. Interesting. Okay. And I really feel like that this requires everyone's input so that when the patient is walking into the building, those people that are working at the front desk are going to have some idea if this person is having some balance problems. Do they trip over the mat as they're walking in the front door? Do they nearly miss the chair when they go to sit down? Well, I think that it would really decrease our incidence of falls within our facilities if we all were to pass on that information to people and to try to do some implementation right away. But once the patient has checked in, then they could be given the Check Your Risk for Falling, which is 12 simple questions. I like this because on the right-hand side, it has information that kind of gives the patient some cues about why this is important for their balance. If they score a 4 or more, then they are at risk for more falls. So what do you do then? Then you would go to doing your screens, which would be timed up and go, the 30-second chair stand, and 4-stage balance test. And these are all validated tests, and they are all available on that CDC website. And also, if you want more information to just know you're doing the tests properly, there is a video there. Although they are all very, very simple, and the information is all there on the website. I also have some of them printed out up here. So let's talk about the timed up and go first. So with the timed up and go, what you need is a chair that has arms, and you need a stopwatch. You can also use your cell phone. And you're going to have the patient sit down in the chair. You're going to measure out a 10-foot distance, which I measured it by, there's a little orange sticker here on the floor, but you would want to put a line there that's more visible for the patient to see. You'd have them sit down in the chair, tell them when I say go, I want you to get up, walk to the line, turn around and come back as quickly but as safely as you can do it. You say go and start your timer. They walk down, they turn around and come back to the chair. Once their bottom touches the chair, you stop the timer. The guidelines for a moderate fall risk are actually 12 seconds. For a high fall risk is 30 seconds or more. So you want your patients to be less than 12 seconds on this. Also, if they have dynamic gait deficits, you're going to see them have problems with the turn. So if you have any concerns about their fall risk, you may want to walk beside them as you're doing this. The 30-second chair stand test, this one always scares me when I do it because I'm not always sure that I can meet the 60 to 64-year-old age group guidelines. And so for this one, you're going to, again, need your stopwatch, and you're going to have a chair that does not have armrests on it. They're going to sit in the chair. They can sit wherever they want, use their regular footwear. You're going to have them put their hands across their chest, and they have to go sit to stand as many times as they can in 30 seconds. These are the age norms. So later today, I want you to just try this and see how you do. I'm not going to have us all do it and embarrass ourselves, but I can meet the guidelines for 60 to 64 today, so I'm good. If they are below that norm, then they would be someone that would have strength deficits that could put them at risk for falls. The 4-stage balance test, again, you'll need a stopwatch. The patient cannot use their assistive device that they would normally use, and they're going to stand with their feet in 4 different patterns. You're going to time them for 10 seconds on each pattern. And these are the 4 patterns. The guidelines for this is if they cannot complete 10 seconds on the third or tandem standing with one foot in front of the other, then they're at increased risk of falls. And this is looking at static balance deficits. So you've gone through the tests, and let's say they have failed one or more of the tests. What do you do then? Well, again, the CDC has listed some guidelines for you. So there is a Stay Independent brochure that you can print out. It's 2 pages. There's also check your environment for your home to make changes. That one's about 8 pages long. But there is also information about strengthening programs. And again, those are all available on the CDC website. Another free resource that's fantastic is this is available from the National Institutes of Health, National Institute of Aging, and it's a book that has balance exercises, strengthening exercises, how to start an aerobic exercise program, and they're free. I think these are great to have in waiting rooms for people to pick up, and if they want one, you can give them another one. But it's a great resource to get people moving and to have them working on strengthening and balance programs. Also, you need to identify if there's some postural hypotension, do a cognitive screen. Medications is a huge one, looking at feet and footwear, use of mobility aids, and making sure they've had a recent visual exam. And if the patient has not had any falls in the past year, but they've failed your mobility screens, they should be referred for a balance retraining or community fall prevention program, such as the one at the Neuromotor Control Lab. There's also Tai Chi available in the area. There are many personal trainers within the city, within the county and outlying areas that are available to work with this. And I've followed up with many of the patients, and they've done a great job with helping them with their balance. So we do have many options available. Also on the CDC website, there's all of the information that you can print out. And, you know, in looking at, I stole this slide from Dr. Spencer's just to follow up, because if you're doing this multifactorial risk assessment and you're doing a community-based strategy, I don't know how those statistics work together, but I'm going to make a wild guess here that you're going to have a significant reduction in falls. So 2 of the things that have been shown to be the most effective in working to improve people's balance and their dynamic gait abilities are physical therapy, and Tai Chi has been shown to be the most effective for community balance improvements. One thing that we have available here in Ames that is very nice is we have the NeuroCom Balance Master. And this was actually developed back in the early 70s for the astronaut program. And I always tell the story of that because I would love to be the first physical therapist in space. I would sign up today. They wouldn't take me, but I'd sign up. But this is still the equipment that they use for the military and for any astronauts that are going to the space lab or anything for them to make sure they're appropriate. So it evaluates the sensory inputs for balance and looks at the motor outputs for balance. I'm just going to talk briefly about the sensory organization test because that's the most common test we do with the NeuroCom Balance Master. So there's 6 different conditions that the patient has to do on that colorful phone booth. The first one is that they have no challenges. They're standing, the platform is still, they have good vision. The second condition is eyes closed, the platform is still. The third condition is that the platform is still, but the visual scenery is moving around them. The fourth condition is that the platform moves, but the visual scenery stays still. The fifth condition, the platform moves and the patient's eyes are closed. That one requires for them to do sensory reweighting and use their vestibular system. And the sixth condition, the platform moves and the visual scenery moves at the same time. It gives me a report that looks like this. Anything in the green means they scored at age norms. Red is below age norms. This test, the person scored 42%. Anything below a 38% would be a very high risk of multiple falls. Between 38 and 50 is a moderate risk of falls. And because they scored poorly on conditions 5 and conditions 6, that tells me that they have some vestibular deficits. But it also goes on to give me information about, on the bottom lower left, about the somatosensory. Now this is somebody else's test from the previous slide, but tells me that they're using their somatosensory system well for balance, using their vision well for balance, but not using their vestibular system well for balance. And the last column there is actually for visual conflict. So can they tolerate that visual scenery moving without them losing their balance or getting sick, which sometimes it does. It also tells me how well they're using their hips for balance, how well they're using their ankles, and it also tells me about how well they're aligning their center of gravity over their center of mass. I could go on and on talking about the many things that the Balance Master has helped me with. And I also know that there has been extensive research done with the use of the Balance Master back to the 70s and the astronaut program. I feel very, very confident with the results that I get on this and the treatments that I'm able to do with the NeuroCalm Balance Master, making a huge impact on the clients that I see. So just some things to take away from this is, number one, think about using those CDC forms, putting them on your desktop and printing them off, having them available in the rooms to hand to patients. Secondly, use your office staff to watch patients as they're coming in and how they're moving through the hallways, and get some ideas of if this patient is at risk of falls, and then acting on that and sending that message on to a care provider. Perform the balance test so that we know if our patients are at risk. And then we need to intervene. Use the handouts that are available on the desktop and print them out as you need to, and refer the patient on to physical therapy, to cardiology, neurology, ENT, durable medical equipment as is appropriate, and follow up with those clients and make sure that they are following those recommendations. Remember that if we can do a multifactorial assessment with the patient and we can add in a community-based program, we can have great success in decreasing the risk of falls with patients. And I thank you very much for your time and attention, and thank you, Dr. Spencer, for letting me participate, and we'd be happy to take any questions now. I did want to mention that if you want any of those forms printed out, you can get one of Emily's cards, and she can email you directly those PDF files for any of those forms you want. I also have some examples of them out here. If anybody wants to come down, and there's not very many of them, but if you want to take a look and maybe take one, that's fine.
Thanks to both of you for this important talk. I think now we have in the Visit Navigator also, I think I got an email yesterday, we're going to have the fall risk assessment too listed. I think it's because of it's going to be one of the quality tools that they're going to measure, I think, from next year, 2015, I guess. So my question, Dr. Spencer, we see most of my patients at this age who have balance problem, most of them also have cognitive problems and urinary disturbance. Which patient, I don't know, I think myself, should I get a CT scan on everybody that I see, or are there any other signs that you would specifically look for to see which patients need to have a brain imaging done to see for hydrocephalus and things like that? So.
Okay.
Well, of course, I want an image on everybody. Sorry, I'm not going to make your life easy. And I just want to tell you, I saw a guy in Marshalltown yesterday. I got his little sticker here. And this is a guy who's in his 70s, and he's had multiple strokes. He's had a bad heart problem, and he's not he's cognitively not doing well at all. And he and his wife were down on the first floor. He was walking with a walker, and not thinking very clearly. And by virtue of physical therapy, by virtue of a wife that nagged the hell out of him, he's now not walking with a walker, just touching her arm as he needs to. So I just want to convince you that these things are a little bit reversible, and it's not a hopeless cause. And I would like to know, for me, if they got cognitive problem, they need to have some image somewhere along the way. If it looks clean and there's no ischemic damage, then yeah, it's all probably Alzheimer's disease, but that still is not the end of the world. I mean, I think with proper intervention, we can keep them from falling and having a bad outcome.
If you're referring a patient to any Tai Chi classes that are around, are they able to accommodate some people that might have some issues such as a post-stroke, or are they able to accommodate some people that have some issues? Or
Yes, actually, through Ames Park and Rec, now the Tai Chi program there, they may have to talk to the instructor and come up with some plans for that. But also through the Story County Senior Services, and also Northcrest actually has someone who does some Tai Chi there. Both of those are well adapted for those people that have balance problems.
I'm just a plumber, but I'm amazed at the CDC. Communicable disease, I thought they were infected disease. How do they get involved with this? Do they do all kinds of things like heart attacks? And why is the CDC? That's not where I would go to look for a neurologic or a physical therapy problem.
Actually, if you get on the website, there are all kinds of things for injury prevention for children, for teenagers, regarding concussions. There are all kinds of options available that you can look at that have recommendations and guidelines for best patient practice.
Including voiding and defecation, and is that on there?
No, look that up and
I
get
mean,
back
I don't
to
know.
us.
I'm amazed by this. I would go to the Center for Medicare. That's where I would think of looking, or physical therapy, your boards or whatever they are.
Yeah.
Anyway,
Well, there is a lot of information, and the National Institutes of Health also has incredible resources for
that makes
balance
sense.
and
Is
fall
this stuff
prevention.
on there? The NIH? Or?
It's not on there, but there
Somebody
are some
needs
other
to
options.
coordinate this. Is what my issue is, that people don't know where to look, and that's what I learned most here today. Which I'd never think of. CDC for this.
Right.
I'd look there for Ebola or something. But
Right.
anyway, you guys fix it.
Very good. Thank you.
Thank you.
Thank you, Dan.
Yes, thank you, Dr. Spencer.